Cancerous of the female sexual organs, female cancer. Precancer cervical lesions, cervical intraepithelial neoplasia, erythroplakia with ATP, leukoplakia with ATP, adenomatosis. Risk factors for cervical intraepithelial lesions. Human papillomaviral infection is a common virus that most women will be infected with at the same time in their life. Smoking, multiple sexual partners, pregnancy before the age of 20, suffering from the conditions that affect the immune system, like human immunoviral conditions. Firstly, let us remind some facts from the anatomy. The vagina, as well as the vaginal part of the cervix, is covered by multi-layer squamous epithelium. And if we are talking about human papillomaviral infection as a risk factor for cervical intraepithelial neoplasia, it means that the upper layers of this epithelium is most common to be affected. But thanks to the squamation of this epithelium, this infection is disappeared in some period of time. That's why this infection belongs to the transition infection. Cervical intraepithelial neoplasia means atypical growing cells, which are present in this multi-layer epithelium or columnar epithelium. If we are talking about mild dysplasia, cervical intraepithelial neoplasia class 1, it means that abnormal atypical cells are present only in the 1/3 of the lining of the cervix. Cervical intraepithelial neoplasia second degree belong to the moderate dysplasia. It means abnormal cells can be found in 2/3 lining of the cervix. And cervical intraepithelial neoplasia class 3 means severe dysplasia. Abnormal cells can be found in more than 2/3 of the lining of the cervix and up to the full thickness of the lining. If we are talking about invasive cancer, it means that these atypical cells destroyed the basal layer into the depth 0.2 centimeters and entered to the bloodstream. What you need for making of the diagnosis cervical dysplasia? Firstly, assurance. You need to perform speculum examination. Traditionally, pap smear should be taken. Nowadays, it's more useful to recommend the woman to pass liquid-based cytology, in which you will obtain more positive morphological cells result. Visual inspection in speculum examination means processing of 3% acetic acid of a cervix and revealing a white spot. Colposcopy, imagination of the cervix under microscope. Cervical biopsy in affected areas, endocervical curettage. HPV testing is obligatory, and co-testing means Papa Nicolau smear and human papillomaviral testing. Traditionally, in Cusco speculum, the doctor should take the smear for oncocytological examination or pap smear. Pap means Papa Nicolau smear. It was the first scientist who firstly described these atypical changes in the columnar epithelium of the cervix. The smear should be taken from squamo-columnar junction. It's the border between multi-layer squamous epithelium and one-layer columnar epithelium of the cervix is the thinnest place in the female cervix. The more thinner place, the more affected by the unfavorable factors. And we are talking about human papillomaviral infection as a risk factor for cervical intraepithelial lesion. The smell should be taken from squamo-columnar junction, which is called as transition zone. Cells are scraped from the cervix and examined under a microscope to check for disease or other problems. For this, you need special brush, the glass or spatula. Such type of brush is better comparing with the previous one because the apex of this brush obtains the smells from the endocervix, and this part of the brush obtains the cells from the exocervix. Frequency of pap smears begin no later than age 21. If patient is sexually active before 21. Once initiated, screening should be performed annually. After 30 years old, for women who have had 3 consecutive normal pap smears, screening frequency may be reduced to every 3 years. And screening may stop after total hysterectomy in the woman more than 70 years old if the patient is at low risk and has had 3 consecutive normal pap smears within the last 10 years. There are 6 types of pap smears. The first one, normal type of smear. Second, A, inflammatory process. Second, B, hyperkeratosis, metaplasia. Third, A, mild dysplasia. Third, B, moderate dysplasia. Fourth one, severe in situ, carcinoma in situ or severe dysplasia. Cervical cancer, the first one, and the fifth and the sixth. Smear is not informative. Here you would observe the correspondence with different classification. Papa-Nicolau, dysplasia classification, Bethesda classification, and histological classification. According to Papa-Nicolau classification, as I have mentioned, we have 6 types of pap smear. And if it means Bethesda classification, which is based on the result of morphological examination in liquid-based cytology, you have negative intraepithelial lesions. Papa-Nicolau classification, the second class, means ASCUS or ASC-H. It means negative or squamous atypia. Set A classification corresponds with the mild cervical dysplasia, and it means low squamous intraepithelial lesions. Histologically, it means cervical intraepithelial neoplasia, the first degree. Set B means moderate dysplasia, belong to the high squamous intraepithelial lesions. Cervical intraepithelial neoplasia, second degree. The fourth one belong to the severe dysplasia, also high squamous intraepithelial lesions, corresponds with the third degree of the cervical intraepithelial neoplasia. And the fifth one means carcinoma of the cervix in all of the classification. If the patient is HPV positive, in all cases, colposcopy is indicated. Co-testing nowadays means HPV testing and Papa-Nicolau smear from the squamo-columnar junction. management of these different classes of dysplasia. Class first, if we are talking about the Papa Nikolaou smears, routine gynecological screening, which was mentioned below. Class second A, the doctor should prescribe appropriate anti-inflammatory treatment and repeat pap smear in 6 months. Class second B, the doctor prescribe also appropriate anti-inflammatory treatment, this hormonal treatment maybe, and repeat co-testing 6 months later. Third A, prescription appropriate treatment according to the obtained changes, continuous monitoring with co-testing 6-12 months later. Class third B, fourth, fifth one, undergo colposcopy, biopsy, endocervical curettage, con biopsy, monitoring, and contesting 3, 6, 12 months. And if you obtain the 6th type of pap smear, it means you would repeat test as soon as possible. If we are talking about biopsy, we mean cone biopsy. A cone-shaped piece of tissue containing the abnormal cells is removed for confirmation of precancer or cancer origin of the cervical problem. As you have seen, in 70% of cases, the cervical intraepithelial neoplasia, the first degree, undergo spontaneous regression. You should monitor for such patients. The patients don't need surgical intervention. You prescribe anti-inflammatory drugs according to the result of bacterioscopic smears. For example, if trichomoniasis were found in these patients, you prescribe metronidazole. In the case of the candidiasis, you prescribe some drugs which are against Candida albicans. In the case of the dyshormonal changes, you try to correct this hormonal disbalance. And in the cervical intraepithelial neoplasia second and third degree, the woman should undergo oncologist for confirmation, histological confirmation of this diagnosis, and these abnormal cells are removed by resection, which is performed by special electrosurgical excision procedure or called knife conization. Cancer of the cervix is the most common female genital cancer. In developing countries, every year about 500,000 women are affected, acquire the disease, and 75% are from frame developing countries. About 300,000 women also die from the disease annually, and of these, 75% are from the developing countries. What are the main risk factors for cervical carcinoma? Human papillomavirus infection, especially type 16, 18, 31, 33, 35, and 6 more. Family history of cancer. Age 35, 55. Sexual and reproductive history. Socioeconomic state. Smoking. Human immunoviral infection. For a long period present or in the uterus intrauterine device. Using of oral contraceptives. Pay attention, students. From initial infection to cervical intraepithelial neoplasia 3rd degree, you need 6 years. And 10 years from 3rd degree to cancer. It means that if the woman has cervical cancer, he have not visited a gynecology during 16 years. What are the main types of cervical cancer? They are squamous cell carcinoma. It is present in 80 to 90% of cancers. Cancer of the flat epithelial cells. Adenocarcinoma of the cervix. Cancer from glandular epithelium, present in 10 to 20% of cases. And mixed carcinoma, most often present of signs of both types. There are 4 stages of cervical carcinoma. The first one, second, third, and fourth. The higher stage, the more organs are involved in pathological process. On the first one, you have only involvement of the cervix. On the second one, involvement the more depths of the cervix and upper part of the vagina. On the third one, you have spreading of this process into the vagina and upper and lower part of the uterus. And in the fourth one, adjacent organs of the true pelvis are involved in this process. The main symptoms of cervical cancer: abnormal bleeding between periods, with intercourse, after menopause, unusual vaginal discharge, and some other symptoms as leg pain, pelvic pain, bleeding from the rectum of the bladder. But pay attention, some women have no symptoms. For diagnosis, you take into account complaints, family history of cancer, speculum examination, cytological examination, HPV screening, bimanual vaginal examination, rectovaginal examination, application of acetic acid and colposcopy, and finally biopsy. What should I do if I have just been diagnosed with cervical cancer? You should discuss that method of treatment options as conization, hysterectomy, radical trachelectomy, radical hysterectomy, combination radiation with chemotherapy. The woman undergo monitoring in the oncologist department. And other considerations: preserve your ovaries and preserve your fertility if you are a patient of reproductive age. In stage, the first one, you have 5-year survival, 81–96%. The second stage cervical cancer patients have 65–87% survival. Stage 3, 35–50% survival. And in the fourth A, 15–20% of survival. Nowadays, you should know about the vaccination in the adolescent by Cervarix or Gardasil for prevention of cervical cancer. Cervarix means human papillomaviral bivalent vaccine recombinant, and Gardasil is active against 4 types of human papillomaviral infection. Who should get the vaccine? Girls at the age 11–12, recommended age group, but can be started as earlier from the 9 years old. Women 16–26 years old. The benefit of the vaccine may be lower depending on prior HPV exposure. The vaccine doesn't work to eliminate current HPV infection, but the vaccination prevents certain types of HPV infection. You can prevent cervical cancer if you vaccinate early, pap test regularly, and HPV testing when recommended by a health care provider. Endometrial cancer precursors. Endometrial hyperplasia, this is the overgrowth of the lining of the uterus. This is the precursor to the development of cancer. Abnormal uterine bleeding is usually the first symptom of endometrial hyperplasia. And in a productive age patient, endometrial hyperplasia defines as thickness of endometrial lining more than 15-16 centimeters. In menopause, more than 4-5 millimeters. All of these endometrial hyperplastic changes accompanied with abnormal risk indicators for endometrial cancer and precursors. Age 60, obesity, estrogen-only replacement therapy, previous breast cancer, tamoxifen therapy for breast cancer, chronic liver disease, infertility, low fertility, chronic anovulation, polycystic ovarian disease, estrogen secretion ovarian stroma or tumors. Classification and diagnostic criteria of endometrial hyperplasia. Simple hyperplasia without cytological atypia. Increased number of glands relative to stroma. Dilated glands with irregular outlines. Crowded clustered glands. Tall columnar epithelium with nuclear pseudostratification. Complex hyperplasia without cytologic atypia. Increased number of glands relative to stroma. Back-to-back glands. Crowded glands with little or no interventing stroma. A hyperplasia with cytological atypia. Variation of size and shape of nucleus. Nuclear enlargement, loss of polarity, post-chromatin clumping, hyperchromatism, chromatin nucleus. All of these changes should be observed in histological examination. On the first page, you would observe the cystic hyperplasia. On the second one, simple hyperplasia. Atypical hyperplasia, the first one, and simple on the second. Confirmation of the diagnosis need to prescription of ultrasound and measurement of endometrial thickness is the main at ultrasound. As I have told, enlargement of the endometrial thickness more than 17 millimeters in reproductive age patient and more than 4 or 5 millimeters in the patient climacterial menopause suggests about endometrial hyperplasia. Firstly, what you should do for such patients all over the world, endometrial biopsy. For this, you need a special catheter which is inserted into the uterus through the vagina to remove cells from the uterine lining and for examination. You should confirm presence of these abnormal cells thanks to endometrial biopsy. In the Ukraine, most common for such patient dilation and curettage is recommended. For the treatment, the first after dilation and curettage, the first line treatment means prescription of the progesterone-containing pills for suppression of high level of the estrogens. For this, you would recommend intramuscular progesterone therapy, medroxyprogesterone acetate, 500 milligrams therapy for 3 months, micronized progesterone, cyclic natural macronized progesterone for 3 to 6 months. Insertion of levonorgestrel intrauterine device, which is called as Mirena. On the first day of menstruation, the doctor inserted an intrauterine device which releases every day 20 microgram of levonorgestrel. It is more suitable, is not so expensive and comfortable for such patients. And finally, gonadotropin releasing hormone analogs for 6 months with sampling every 3 months is a reasonable option in patients without atopia. What are the main risk factors for uterine cancer? Early menarche, late menopause, overweight, never had kids, sporting or abnormal vaginal bleeding, and bladder infections. Here you would observe the uterine cancer. All layers of the endometrium, of the myometrium, is involved by this abnormal growing tumor. Staging of the uterine carcinoma, grade 1, according to histological grading system. Well-differentiated carcinoma consists of a neoplasm with less than 5% of solid cancer. Grade 2, moderate differentiated carcinoma, contains between 6 and 50% solid cancer. Grade 3, poorly differentiated carcinoma, is made up of more than 50% of solid tumor. Modified classification of the endometrial carcinoma. Endometrial adenocarcinoma, cirrhosis carcinoma, clear cells carcinoma, mucinosis carcinoma, cirrhosis carcinoma, mixed types of carcinoma, and undifferentiated carcinoma. There are 4 stages of endometrial carcinoma. In the first one, you have involvement of the endometrium, some parts of the myometrium. On the first one, the higher stage, the more involvement. And in this fourth one, you have involvement of the adjacent organs. Clinical signs: irregular vaginal bleeding, intermenstrual or postmenopausal. Watery vaginal discharge may be present in postmenopausal women and present of the mass in the late stages. What you need for investigation of the endometrial cancer: transvaginal sonographical investigation and biopsy, hysteroscopy and biopsy, computer scan or magnetic resonance imaging. All of these methods should confirm the presence of the endometrial carcinoma. At ultrasound, you will obtain the enlargement or thickness of endometrium lining. For confirmation, you need biopsy, and during pipal biopsy, you would obtain these cells from the uterine cavity, which should be sent to histological examination. Treatment: operative total abdominal hysterectomy and bilateral salpingo-oophorectomy, plus minus lymph node dissection in the operation is the choice. Adjuvant radiotherapy for the grades, for the stages more than first B. Chemotherapy in the endometrial cancer is ineffective. Hormonal therapy in some cases is indicated in reproductive age patients. You will start from progesterones in early or recurrent cases. 5-year survival rate for endometrial cancer. In the first A degree stage, 91% survival is present. The higher degree, the higher stage, the less percent of 5-year survival. And as you see in the stage 4, you have 17% of cases survival. Ovarian cancer is the second most common gynecological malignancy. The most frequent cause of death from gynecological cancers, due to advanced stage at the time of diagnosis. 53% of all deaths from gynecological cancers. Incidence increases with age, most marked beyond 50 years old, with increase continuing to age 70 and decrease after age 80. Risk factors: family history of cancer, personal history of cancer. Women who have had cancer of the breast, uterus, colon, or rectum have a higher risk of ovarian cancer. Age over 55, never pregnant, menopausal hormone therapy like estrogen taking. That's why nowadays, if you would recommend the patient to take estrogen in the menopause, you try to suppress this estrogen by progesterone prescription. Classification of ovarian cancer: primary, neoplasm derived from the ovarian surface epithelium. Secondary, neoplasm derived from papillary or pseudomucinosis cyst adenomas. And metastatic, intestinal and breast metastasis. Classification of ovarian cancer: surface epithelial, ovarian cancer is present in 65–70% of cases. Cirrhosis, adenomas, mucinous, endometrioid, transitional cells as Brenner's, clear cells. Stroma in 15–20% of cases. Granulosa cell tumor, tecoma, fibroma, Sertoli-Leydig cell tumors. The third one, germ cell tumors in 5–10% of cases. Teratoma, benign cystic dermoid cyst, solid immature cyst. Monodermal, like ovarian stroma, carcinoid. Dysherminoma, yolk cell tumor, choriocarcinoma, mixed germ cell tumor, and metastatic tumors. In the picture you would observe the cirrhosis cyst adenoma large sizes, serous. Papillary cirrhosis cyst adenoma, like borderline. Pay attention to the internal surface of this capsula, which is filled by abnormal papillary growings, which suggest presence of cancer. Papillary cyst adenoma. Ovarian tecoma, students, it is solid tumor with variegated yellow-orange appearance. Produces estrogens. Metastatic Krukenberg tumor. It means involvement of the stomach. Primary origin of the cancer is stomach. And secondly, ovaries are involved in the pathological process. Classification of the ovarian cancer. There are also 4 stages of ovarian cancer. In the first one, most common ovaries both are involved. On the second stage, involvement of the uterus, fallopian tube, other pelvic organs are present. And the third one, you have peritoneal involvement. And in the fourth stage, you have distant metastasis. Silent killer is most typical for ovarian cancer. It means, what are the main clinical signs of the ovarian cancer? They are bloating, pelvic or abdominal pain, pain in the back or legs, diarrhea, gas, nausea, constipation, indigestion, difficulty eating or feeling full weakly, urinary symptoms, pain during sex, abnormal vaginal bleeding, trouble breathing. The picture you would observe the patient with the ascites as a result of the ovarian cancer, enlargement of the abdomen, dyspnea, presence of the fundus in the true pelvis. Diagnosis means physical examination, pelvic examination in which you revealed the pelvic mass by rigid or irregular contours, large sizes. Rectovaginal examination would reveal the metastatic involvement of the posterior cul-de-sac and presence of the tumor in the true pelvis. Ultrasound revealed the tumor. Magnetic resonance imaging will confirm presence of the tumor and local and distal metastasis. Cancer 100 antigen 125 high false positive rate is more better to recommend HE4 marker, which is more sensitive this cancer antigen 125. And finally, laparoscopic investigation. The combination of HE4 and cancer antigen 125 was more sensitive than either marker alone. Risk of ovarian malignancy algorithm index Roma is calculated. And ovarian cancer treatment nowadays, in most commonly you would prefer surgery. Combination of the chemotherapy with surgical information is more useful. Chemotherapy alone will give you less positive results. And surgical chemotherapy and radiation also is recommended. The 5-year survival rate for all stages of ovarian cancer is 45%. For cases where a diagnosis is made early in the disease, when the cancer is still confined to the primary site, the 5-year survival rate is 92%. And nowadays, it is better to prevent cancer of the female sexual organs. For this, eat healthy, be active, be screened, be a healthy weight, be smoke-free, and limit alcohol.